Good afternoon and welcome to the SHIP Improving Care Transitions Among Multiple Care Providers in Rural Areas. I'm Karen Kennedy with the Indiana Hospital Association. I'm joined here with several of my colleagues. So welcome. There's a couple housekeeping items. If you could keep your phone on mute throughout the presentation, we will open it up for questions and answers towards the end. But certainly use the chat function throughout the presentation to ask any questions. We'll be monitoring those questions and either be providing those answers at the end or by using the chat function as well. If you could also, in the chat function, write in your name and organization. It'll be very helpful for us to know who's joining us today. Today's topic is regarding COPD, and we're joined with Tina Hilmes with the Center for Patient Safety. Many of you met Tina when we did our regional roadshow back in, I guess that was January. So this time we're going to turn it over to Tina. Thank you, Tina.
Thank you, Karen. So today we're going to talk about COPD, but I'd just like to do a quick run through of the objectives of this project. And it's basically to provide training and tools that will help assist the transition of high-risk patients, especially those with chronic diseases such as COPD, to increase the knowledge of shared accountability and just culture, and to also develop and share communication tools and techniques. So today is on chronic obstructive pulmonary disease. And I'd just like you to kind of keep in mind as we're going through this, think about that we all probably interact with patients with COPD on a daily basis. And we probably also know people personally who are struggling with COPD. So think about how we are currently treating them, how treatments have been kind of in the past, and where we would really like to go with these patients, because this has actually become a highlighted topic of interest nationally since about 2017. So today's objectives are to do a brief review of the pathophysiology and present some statistics regarding COPD, introduce some of the components of what go into a COPD care bundle, and then identify some of the roles of community partners and family members. So why specifically COPD? Well, COPD is the fourth leading cause of death and disability. The prevalence and deaths due to COPD is expected to increase even more over the next decade. Approximately 20%, or 1 in 5 Americans, has been diagnosed with COPD, which equates out to about 16 million people have been diagnosed with COPD. And then COPD kills more than 135,000 Americans annually. So let's do a little review of really what COPD is. We hear it out in the community, and even when we talk, we hear COPD, we hear emphysema, we hear chronic bronchitis, and amongst patients, I especially hear, oh, I don't have COPD, I just have chronic bronchitis, or I don't have COPD, I was diagnosed with emphysema. And so even just the moniker, the term COPD, doesn't really seem to be understood that well, even amongst patients, and I am guessing even among some healthcare providers also. COPD is basically progressive lung diseases that are characterized by increasing breathlessness. That includes chronic bronchitis, emphysema, and refractory non-reversible asthma, and also the 1-alpha antitrypsin genetic disease. Currently, there's no cure for COPD, but with correct diagnosis of which component you have and treatment, it is manageable. So let's go into just a real brief review of the pathophysiology of each of these. So chronic bronchitis is technically inflammation of those bronchial tubes that go down into your lungs. They get inflamed, they produce excess mucus, and the person will present with persistent productive cough, wheezing, shortness of breath. And when I say chronic, it means it's been going on consistently for 3 months. This isn't someone maybe who has asthma and has an acute bronchitis for like 7 to 10 days, goes a week, a month and a half, and they're fine, but then they get another exacerbation. This type of patient to be identified or diagnosed with chronic bronchitis have their symptoms consistently persistent with no remission for 3 months or more. And chronic bronchitis usually develops into emphysema eventually, especially if the patient doesn't do any lifestyle changes like smoking cessation or learning how to pace themselves. So causes and treatment, as we all know, the number one cause of chronic bronchitis is smoking. Other causes can be repeated upper respiratory infections, exposure to secondhand smoke, chemicals, air pollution. The treatments for chronic bronchitis include inhalers, emergency inhalers, the new inhalers, well, they're not so new anymore. They've been out for more than a decade now, but the combination ones that are a combination of a long-term bronchodilator along with a steroid. And those types of inhalers are not meant for immediate relief of any wheezing. Rather, they are to be used to help prevent any type of wheezing or exacerbation. Oxygen can be used for chronic bronchitis, and then other treatments include pulmonary rehab and lifestyle changes such as smoking cessation. Emphysema, on the other hand, is damage specifically to the alveoli. They present with some of the same symptoms, such as a persistent productive cough, shortness of breath, wheezing, chest pain, but these types of patients tend to be susceptible to frequent upper respiratory infections. Again, the causes are very similar. Number one cause is smoking, repeated infections, secondhand smoke, etc. Treatments, again, are very much the same. The combined inhalers, emergency inhalers, nebulizer treatment, oxygen, pulmonary rehab, and then lifestyle changes. So what are the differences then between the two? Well, chronic bronchitis pertains to specifically that inflammation of the bronchioles. Those can be reversible to a degree. If they're having an exacerbation, you can give a breathing treatment. It will help decrease some of the inflammation. You can give prednisone or steroids orally, and it can help reduce some of the inflammation. But the basic disease is long-term. It'll never go away completely. Whereas emphysema is no component of it is reversible, and it is also progressive, and it involves permanent damage to the alveoli. And the one thing I'd like to say is that if chronic bronchitis isn't monitored and managed, it will turn into emphysema, because that damage to your lungs and the frequent exacerbations of chronic bronchitis do cause permanent damage and scarring to the lungs, which will eventually go into emphysema, and especially if these chronic bronchitis patients refuse to quit smoking. And so some takeaways that I really want you to think about as we move forward to the rest of the presentation in regards to COPD is that they are truly medically fragile. I think in this day and age, because we see COPD patients so frequently, we interact with them in the community. We may even have family members who have been diagnosed with COPD, is that we've become a little complacent about it because it is so common and we do see it so frequently. And we truly forget that these types of patients are extremely medically fragile. They are definitely susceptible to pneumonia, influenza, cold. Because of the strain that is put onto their heart and the cardiac system, They are susceptible to cardiac issues. If you think about it, the more that you struggle to breathe, the harder your heart has to work, and so the more stress and strain you put on your heart. So you'll find more often than not that your end-stage COPD patient also will have left-sided heart failure. And that is because their heart has been working so hard to try and assist them with their breathing. These types of patients also, due to the fact that their socialization, their ability to socialize with family and friends and to go out into the community is decreased, they do have an increased susceptibility to depression. And then the last thing that I'd really like you to take away from this is that COPD really affects patients differently. I'm not really going to go into like the stages of COPD here. Rather, what I'd really like to do is take this brief review of pathophysiology and develop some community tools and care plans that we can do to help manage these patients. But keep in mind, with the staging of COPD, whether you're at stage 1, 2, 3, or 4, that is all based on pulmonary function tests. And what research has shown is that pulmonary function tests don't really give the whole picture. You can have 2 patients who are diagnosed at stage 4 COPD. One is on oxygen all the time and can walk 20 to 30 feet without getting short of breath. They have that amount of reserve. But you can have another patient whose pulmonary function tests will show that they also are at stage 4, but their oxygenation component of COPD is good enough that they don't need oxygen, but that ventilation component is much more severe, and they can only walk 5 or 10 feet before they get short of breath because they just don't have the reserve, because they don't have the appropriate ventilation, and that could be because they're at a stage where their heart is more affected. So that's one of the reasons why I don't want to go into stages, but it's also the point as to why I want you to understand that COPD affects each patient differently. So here are some more COPD statistics. So I had mentioned earlier that 16 million people in the United States have been diagnosed with COPD, but there are many, many more who exhibit the symptoms of COPD but remain undiagnosed, which this can lead to an issue because by the time they're diagnosed, they might be already into emphysema, they might be already into some of those more difficult to control stage. COPD also causes serious long-term disability, and that gets into productivity and being able to maintain an income and even health insurance to help pay for what they need to maintain and control their COPD. The rates of COPD are actually highest in the Southwest, Southeast, and Midwest. The cost currently is projected to be $49 billion by next year and expected to continue to increase by 2030. So this little map that I have over to the side is basically an adjusted death rate of each of the states throughout the United States. And I wanted to highlight this because all of you are Indiana, and show that Indiana actually right now is in that group of states that have one of the highest death rates due to COPD, which makes managing and trying to figure out how to control and manage COPD in the community really important right now. Some other national statistics is that when it comes to readmission, the rate for COPD readmission is 1 in 5. And in fact, it's the 4th leading cause of 30-day readmission. And then some things that go into those readmission statistics is inappropriate use of medication. What we're finding on reaching out and doing some research to try and figure out why there's such a high incidence is that many of the patients are not utilizing their inhalers appropriately. They don't know when to take their medication. Many are sent home sometimes with a prescription of steroids, of prednisone, to take if they start having symptoms, but they don't understand what those symptoms are that might cause them to need prednisone. They don't understand why they need to use a spacer. Another cause of readmission is failure to receive appropriate referrals. Are they being referred to smoking cessation classes? Are they being given a referral for pulmonary rehab? We are failing to do appropriate follow-up. Are we going ahead and making those appointments for them and ensuring that they have transportation to make it to those appointments? So these are all key components that lead to COPD exacerbation, which then can lead to readmission in the hospital. So if we drill down even more into Indiana specifically, nearly 8% of adults are diagnosed with COPD in Indiana. 53 people out of every 100,000 die annually due to COPD. And I might make a note here that this could be even an underestimation, because many times patients who die of COPD, what is listed as their cause of death is multi-organ failure. So it isn't listed as multi-organ failure due to COPD or due to chronic bronchitis. It's not listed that way. It's just listed as multi-organ system failure. So we might even be underestimating the number of people who die. Right now, currently, and I believe this was actually from 2014, the cost of COPD in Indiana is $782 million. And then their readmission rate is even a little bit higher than the national readmission rate. And again, I was able to find a map from the CDC, which kind of highlighted where Indiana is in regards to the prevalence of patients diagnosed with COPD over the age of 18. And you can see they're in that, you guys are in that group of states that have a higher prevalence. So some of the statistics, some of the takeaways I really want you to get from these statistics is that we really need to have an increased awareness of COPD, not just in the hospital, but across the whole continuum of care and within the community. We need to focus and increase our education, and we need to really start this collaborative effort of a collaborative care team across the whole community. And we need to really look at the type of communication we have that helps to manage and monitor these patients so that we can keep them functioning as independently as possible in whatever environment they call home. It could be an actual home, it could be an apartment, it could be assisted living, whatever they consider home. Let's try to keep them functioning as optimal as possible in that environment. So all these statistics also led to a COPD National Action Plan. And the work began in this in 2016 as hospitals were really focusing in on readmissions. And it really came to light that COPD was a problem. And so the report was put out or published in May of 2017, so not even quite 2 years ago. One of the other reasons work began on this is that as they were looking at like the Department of Labor and labor statistics and causes of disability, again, COPD cropped up as the fourth leading cause of disability. So that was another red flag. And then as these researchers and authors started looking at it, the death rate for COPD has actually doubled since 1969. And what they've also noticed is that 8 in 10 COPD deaths can be directly related to smoking. So could be prevented if we could keep people from smoking or have them stop soon and keep them from getting into that like 2-pack a day for 30 years. So that led them to believe that a comprehensive unified framework really needed to be developed to help address the COPD issue. So they developed 5 goals. The first goal calls for promoting more public awareness and understanding of COPD, especially among patients and their caregivers. The second one was to focus on increasing the skills and education of healthcare providers so that all of us are better equipped to provide care to those with COPD. The third was to increase data collection and analysis and sharing to create a better understanding of COPD. The fourth goal was to increase and sustain research to improve the understanding of the disease, to help improve the diagnosis, and also to improve treatment. And the last goal was to call for not only federal but also non-federal partners to collaborate to help translate these goals into the public and translate them into more research. And so the important takeaways, I'm not going to go through, it's like a whole close to 70-page report. It had a whole PowerPoint. So I'm not going to go into every detail of this report, but the takeaways are that as healthcare professionals, we can empower our patients, we can improve our own practice, and we can start by identifying patients in our community before they become really severe. We can identify and engage with partners with the ability to reach these populations that are most affected by COPD. We can maybe look around the community and meet with one another across the continuum and maybe develop COPD registries that help identify these patients to help improve management. And then we can share in the community with all kinds of different partners the highlights of the COPD National Action Plan. And with the handouts for today's presentation, I've also included a toolkit of the COPD National Action Plan so that you all have that. I thought that might be interesting for you to have so that if you do want to start looking at putting this into action in your community, you at least have a toolkit as a foundation. So let's look at really how currently we handle COPD patients. And think about it, if we have a COPD patient, we really kind of handle them more in our own way, in our own environment. You could have a patient stay in a long-term care facility who maybe has a child come a couple of days a week to help them with any type of exercise, with pursed lip breathing and symptom spirometry, asking them if they're being good about taking their inhalers. But maybe that child travels a lot for their work because they also work full-time. We don't really do a good job of making certain that aides or whoever's going in then to see the patient on a daily basis is following up with doing those caregiving actions that maybe that child was doing, of making certain that the patient is doing in symptom spirometry or is practicing their pursed lip breathing or making certain they're being extremely compliant. We don't really develop a community care plan right now. We kind of know when we get someone, let's say you've got a patient in the community who lives at home, but they frequently have to be picked up by EMS, taken to the hospital. Hospital discharges them to a facility where they stay for a couple of weeks, do some pulmonary rehab, then they're discharged home, and then 3 months later it starts all over again in the cycle. And so we know that they're a frequent flyer, we know them in the system, but we don't really reach out to one another to say, you know, EMS, do you know what inhalers they're supposed to be doing? Can you check up on them? And we don't do real frequent calls, and we haven't been good in the past about giving them warning signs of what to do. So we've been kind of really doing it in our own little silos. And with that, then, we don't really know what the patient's baseline status is. The hospital and ED and EMS only see them when they're in an exacerbation. So they don't have all of the information that that maybe the primary care physician has, or if they're seeing a pulmonologist has through pulmonary function tests. They don't know what that baseline status is. And likewise, long-term care, if they do go there frequently for rehab on an inpatient basis, they will know what they're like as they're getting ready to discharge, but they may not realize that maybe that is the patient's baseline, that's their most optimal functioning status. So, you know, there's this lack of knowing the patient throughout the whole system. And then we're not real good about sharing with one another that the patient does have a good support system or doesn't have a good support system. You know, some patients, like my mother, for instance, I had a mother with COPD. I was there every day checking up on her. And there are other patients that maybe have spouses, but their spouses don't understand the medication. And so that's not, they can give them emotional support, but they're not really good at helping them with their care plan. So we're not all aware of what type of support the patients have once they're home. So we can start by, in the hospital, as these patients are admitted, especially if they're brand new diagnosis, is developing a multidisciplinary team and making certain you include respiratory therapy and pharmacy. That way we can ensure that the patient is prescribed the appropriate inhaler because, and I'm not certain everyone is aware of this, but we all know that there are multiple different combination inhalers these days. I'll take three, for example. You've got Dulera, you've got Symbicort, and you've got Advair. All of these are combinations of a long-acting bronchodilator and a steroid inhaler. They're all just a tinge different from one another, but it doesn't mean they're interchangeable. Each patient responds differently to different ones. I'm a severe asthmatic, and I've tried all of these, and Dulera doesn't work for me at all. Symbicort somewhat, but as long as I take Advair on a regular basis, I'm good, and I probably won't see an ER for years at a time. And COPD patients are really the same way. So we really need to make certain, and it might take a couple of trials, a couple of weeks, you know, of a patient trying a certain inhaler to try and figure out which one does work best for them. We need to make certain that RT is teaching them appropriate utilization, making certain they understand why they need to use a spacer, understanding that if they don't use the spacer, many times the medication ends up either at the back of their throat or on their tongue. As we did research, a lot of these patients still didn't realize why they needed to use the spacer with their inhaler. As we discharge them, make certain they've got a 30-day supply of medication. Give them a 15-day follow-up appointment. Make certain you get social work involved. Discharge them with home health if they need. You know, evaluate their resources and support systems. Set up pulmonary rehab and smoking cessation, and give them like a one-page action plan that they can put on their refrigerator. And it goes through not only what symptoms for them to monitor, but what actions to take. So long-term care does face some challenges. When you look at long-term care, their rate of COPD in their facilities is very similar to U.S. statistics. It's like 22%. And they face a few more challenges in their patient demographics because they will have patients that have impaired cognitive skills, Alzheimer's, dementia, short-term memory problems. We're not always real good at educating our aides as to the varying components of COPD and bringing them on board as a team member to help monitor the patient and to help identify those warning signs. Your aides are really your diamonds in the rough because they're in there every day. They're in there helping the patient. They are the ones who truly know that baseline status. So they've got just a wealth of information, and then just making certain that we can give them the educational component to be able to identify patients as they start to slip into those exacerbations. Long-term care also many times doesn't get all of the information from referring hospitals that maybe they need to help keep their patients or to help understand what the care plan was in the hospital and what they would like to keep ongoing. And then also long-term care has these challenges of not always having an RT available and, you know, maybe not having some of those resources readily available that hospitals have. So with long-term care, though, there are some things you can do, such as developing teams and really sitting down with the hospital discharge team to make certain that they know the care plan of the patient. EMS there's other challenges with EMS with these types of patients. Because a large challenge is a lack of history. If this is an unknown patient, you can be going to pick up a patient who seems to be wheezing and short of breath, but is it asthma? Is it COPD? Is it something else going on? Maybe they've got an acute bronchitis going on. You know, that can be difficult to know. One thing to know is that the majority of COPD patients will be older than 50. So that's something to keep in mind that can sometimes help in EMS. One of the other things to help EMS identify these patients is to assess smoking history and and if they are currently smoking. And it can always help to find a medication list or find what medications the patient is taking in the home. Sometimes you have the opportunity to find that. Sometimes it's a time critical situation and you don't have that time. Always provide oxygen. I know we've all heard that we don't want to provide oxygen because it can knock out the respiratory drive. But what current research has shown is that in the first 24 hours, when a patient's having an acute exacerbation, increasing their supplemental oxygen is not going to knock out their respiratory drive. It's only if you maintain that increased supplemental oxygen for more than 24 hours. So if you're going to pick up a patient and you're not aware of their history, or even you are aware of their history, but their O2 stats are showing that it's like 88, 87, 89, go ahead and turn up their oxygen if they're on supplemental oxygen to get those stats up to 92, but make certain you're not going up to 100. And then the last thing I would say to EMS as you're working with these patients and trying to get them transported is always make certain before you start any type of positive pressure ventilation or nebulizer therapy, make certain you rule out any other underlying pathology of the shortness of breath, making certain it's not like a PE or anything like that, making certain that, you know, even in an acute, you would probably do some of these things, but making certain there isn't anything else going on that might be affecting their oxygenation and their ventilation. But just think about, you know, as we are saying, you know, right now these are the challenges. If you were to go into the home or be called to a patient whose home you've never been called to before, they're a new patient, it's not a trauma, but yet if this patient were in a registry or on a list of patients that you knew had been recently diagnosed with COPD and now you're being sent out on a call, how much that could help because you already have that information in hand as you're going out to see that patient. So the goal of CARE with this National Action Plan is to really integrate all systems in the care of the COPD patient. It's to standardize the care and it's develop a care plan that is evidence-based. And by doing this, our goal is to reduce rehospitalization. And if this is a known diagnosed COPD patient, if they do have an exacerbation, by knowing what their care plan is, knowing what works for them, we can hopefully reduce their length of stay or maybe even keep them from going into the hospital. One of the challenges with COPD patients is since they are so susceptible to infections such as influenza, if you admit them to the hospital, you're just increasing the risk of them being exposed to someone with influenza. So if you can keep them in their home environment, you might be able to reduce the risk. So, you know, if we can try to keep them from being hospitalized or rehospitalized, that's always the best plan of action. And continuing in the community, some of the goals going forward to help us managing the care of patients with COPD is to develop a shared registry of patients in your community that do have COPD and suffer from it. To start integrating your community paramedicine, I know EMS, this has been like a big thing on the front of starting to use EMTs, paramedics in community paramedicine, using them as mobile integrated healthcare units, reaching out maybe on a weekly basis and monitoring these patients who have these chronic diseases to help maintain them at home without the exacerbations. In the community, another goal is to communicate regularly regarding these patients and to have a continual assessment for depression. As mentioned earlier, these patients are at risk due to the fact that their independence is slowly being taken away from them in many situations. If the patient is at home, EMS and hospital can reach out on a regular basis. If they're in a long-term care setting, engage a core care team in your facility to care for these COPD patients. Include dietary, include your aides, include any type of PT, any type of healthcare provider who might be involved in helping these patients with pulmonary rehab, to help monitor their symptoms and to help keep them, at a stable level without going into the hospital. So the goal is then, as mentioned before, to maintain the patient functioning as independently as possible in their home environment. So I've given you all this information. Let's kind of take a look at a case example. And in this example, this patient was not diagnosed with COPD or emphysema or anything. And so as we go through these steps, think of how things might have been differently and how the symptoms might have been noticed earlier had this patient been diagnosed earlier. So Mr. Jones, 68-year-old assisted living patient, tells us that he has been feeling kind of under the weather for a few days. The aide is concerned because Mr. Jones doesn't look quite right. A nurse is summoned to assess the patient. Upon review of the medical history, there is no diagnosis of COPD listed, but Mr. Jones lets the nurse know that at one time in his past, the doctor had told him he thought Mr. Jones had emphysema, but there was no documentation of any follow-up lab work being done, no pulmonary function tests had been scheduled or done, but Mr. Jones does have a history of smoking 2 packs per day for 30 years. So the current assessment of this patient is that he's alert and oriented, but he does have significant diaphoresis. He's using accessory muscles to assist breathing. Radial pulse is bounding, which is indicative of his heart having to work harder to help him breathe. You hear wheezes in the upper lobes and the apex of the lobes, and then minimal air movement in the bases. And vital signs are he does have a fast heart rate, fast pulse. Respiratory are up a little bit, and blood pressure is elevated a little bit, all showing that he's struggling right now. So EMS is called. Assessment for them aligns with the nurse assessment, but when they do a pulse ox, the SpO2 is at 85%, and they note that a temp is 101.8, which that could be indicative of multiple different things. It could be pneumonia, it could be influenza, it could be a bacterial infection. We don't know, but obviously something is going on with Mr. Jones that is causing him to struggle. O2 is started, that's for cardiac issues, lung sound equal, nebulizer then started because there don't seem to be any other cardiac issues where nebulizers might interfere with that. As they do the oxygen and nebulizer, they get the sats up, increase or transport the patient to the hospital, admit to ICU, and upon further assessment, there's an infiltrate consistent with pneumonia. Antibiotics are started, and then Mr. Jones is moved to the floor after 3 days and diagnosed with COPD, emphysema component. So immediately an interdisciplinary plan is started. They bring in RT, they bring in pharmacy, they prescribe an inhaler. Pharmacy reviews current meds and reviews any new meds that might want to be prescribed to make certain that nothing will interact with those current meds. A plan is set up for pulmonary rehab, screen for depression, etc. Family is brought in. The family is taught the care plan and warning signs. A social worker is brought in to evaluate resources, set up a care plan. The social worker also evaluates the support of Mr. Jones, assesses health literacy and insurance. So then he is also entered then into a registry of COPD patients into the community. And along with his name, is a note of resources he has, his primary care physician, his current meds, and what his current care plan is. A community team of a long-term care facility, EMS, maybe bring in home health also, and hospital meet to discuss the new addition of the registry and Mr. Jones' plan. He is then transferred to the long-term care facility, pulmonary rehab begun, smoking cessation classes begun. Members of the care team in the long-term care facility brought onto the interdisciplinary team, help Mr. Jones continue with his pursed lip breathing, teaching him how to do it, reinforce the appropriate use of inhalers, and also the compliance with his medication. If Mr. Jones is discharged home, or even after he's discharged home from pulmonary rehab, you know, he should be maybe discharged with an O2 concentrator. In this instance, he was. So he should receive a weekly call from that care team or visit. Or maybe you prescribe him home health, who then also meets with and communicates with EMS and the hospital team on a regular basis to let them know the status of Mr. Jones. Social worker meets in the home to ensure that Mr. Jones does have appropriate resources. Smoking cessation classes begin or continue. And so then you have a plan of maintaining Mr. Jones in his environment that he considers home and trying to keep him at a stable level, at his optimal functioning level, without going into the hospital, and everyone is aware of what's going on with him. So in summary of everything, what I'd like you to take away from this is that COPD is a national problem. It is a leading cause of death and disability. It's projected to cost $49 billion by next year, and that up to 80% of COPD cases are preventable. This is something that just boggles my mind. If we could really get that smoking message out there, I realize that's not going to affect every single person who has COPD, but it will help with so many and maybe help prevent a greater number of cases. The care for COPD needs to be interdisciplinary, it needs to be standardized and evidence-based, and it needs to be focused in on reducing rehospitalization and length of stay if a patient does get hospitalized. And when I mention interdisciplinary, it means all healthcare members across the whole continuum, aides, MDs, EMTs, RMs, pharmacists, nurses, and it includes EMS, long-term care, hospital, home health, everyone across the continuum of care. And then we really need to look about starting that COPD patient registry. I know when I was doing home health, we always had a list of our priority 1 patients to check up on whenever we were doing like a tornado warning came along, or we'd had a huge storm come through. There were those priority patients that you checked up on when that happened. These types of patients need to go onto that list. They need to be checked up on and followed up on. And by creating this COPD patient registry, we can really evaluate clinical care and treatment. We can work towards improving the management of the patient and reduce rehospitalization. And before I go to opening up for questions, I would like to say, in regards to the project, overall project, we've talked about the culture surveys that we have for EMS, for long-term care and hospitals. Included with this project is a culture survey. And so it really is a great starting point for moving forward. And it is free since you're involved with this project. So really take advantage of this. But to do this, we really need to know that you'd like to do this by close of business on Monday. So please either let myself know or let Shelby know. We'll include my email also and any other notes in an email that goes out with the recording and the handouts from this presentation. But please take advantage of this. It really is a great tool for moving forward. And so with that, I'd like to open it up to any questions.
Anyone have any questions for Tina? Or do you even, would you have a best practice that you'd like to share, or something that you're working on that's maybe centered around COPD patients?
Becky Hancock. I just posted in the chat. I just posted in the chat room a link that a study that was done that improved, reduced pneumonia occurrences for patients by improved oral care with twice-a-day toothbrushing and a mouthwash with non-alcoholic mouthwashes in order to reduce pneumonia occurrences, and that could greatly improve the quality of life for COPD patients if they were at reduced risks of pneumonia.
That's a fantastic share. Thank you so much.
So Tina, maybe if you could summarize, so you know, the hospitals are working with their EMS and their long-term care facility. What would be a good starting point?
I know that the base charger, you know, the one that that we plugged.
Sorry, Tina, you can go ahead. Sorry, Tina, are you there?
Yeah.
Yeah, go ahead.
So I think a good starting point, actually, for going forward is maybe to, I think first you have to have all of the foundational components in place. And so it would be maybe setting up a meeting with your EMS representatives and long-term care representatives and your hospital representatives and discussing how you can start this. And maybe starting with a certain date of, we'll say May 1st, we will, you know, get together and start a list of who we know who has COPD, or start with, okay, on May 1st, we will start implementing this care bundle that if anyone is admitted to the hospital with what seems to be an exacerbation of COPD, we will put them through this care bundle and evaluate them as if they're a new diagnosis. And then we will hand off to our partners, including long-term care and EMS, bring them on board and begin the steps then. But I think a good starting point is just to start first with a baseline meeting of everyone saying, okay, this is a good plan. We need to start doing this and get the steps. Okay, we want to do a registry. We want to start in on the hospital side with a team. We want to start in with long-term care with a core team and who it will include. And then start in with, okay, once we have those steps, then on May 1st or whatever dates you decide upon, we will start implementing, you know, the care bundle steps, and we'll start putting people through this system, including primary care physician and all of our community partners. And so that if you do that and you've got those foundations built and you've re-educated your caregivers, your aides, and your teams in the hospital and long-term care, you've reached out to primary care physicians, say clinical offices in the community, to home health providers in the community and EMS, then you can really begin that process of including everyone and putting people through the system, through the pipeline.
Good, thank you. Well, I don't think we have any other questions or comments, so we will give 10 minutes back to you today. We will be sending out the PowerPoint as well as the toolkit that Tina referenced. So we'll be getting those out to you maybe even today. So keep a lookout for those. And then also, if you're interested in taking the Culture Patient Safety Survey, you know, please let Tina know by Monday, especially if you're a long-term care facility or an EMS. It's a very unique survey to you. Some of the hospitals have taken that culture survey with IHA, but certainly, it's offered to use through this project as well. So at this time, we'll go ahead and end the call, and thank you everyone for joining us today.
Thank you.
Thank you, Tina.